Okay. The topic that I'm talking about is metabolic disease in pregnancy. And this is something that we cannot get out of, the problems that you're facing in pregnancy, both antenatally, intrapartum, and postnatally, with the rise in obesity and diabetes. And very often it gets pushed to the background. We are more focused on the immediate obstetric complications, but less on what are the factors that are predisposing these women to these complications. But also more importantly, in the long term, because as obstetricians, we do not see the mother 6 weeks postnatal, and then they enter into the general population and get lost in the system. So just want to today focus on some of the key conditions that we can make a difference as obstetricians. And I would like to focus on two such conditions. One is gestational diabetes, and the other one is obesity in pregnancy. And I would like to focus particularly with regards to GDM on prediction and prevention, and also highlight some of the interventions for reducing weight gain in pregnancy. So gestational diabetes first. So why do we actually need to predict gestational diabetes? I do understand that we work in different health systems here in UK and with many of you in India and other countries. However, it is also a problem irrespective of the country you are in. We also do have a large number of women with predisposing characteristics for GDM. And we really want to provide this targeted care to these groups. So with the rapid rise in the prevalence of the condition, we have to optimize the use of the resources as well as manage as early as possible to prevent not just GDM, but also its complications. So what are the different tools that we currently have to predict GDM, and how accurate are these? And traditionally, we go by history, and that's the reason a lot of us do a glucose tolerance test in those who are considered to be a high risk. There are also individual tests that could be considered to be predictors of GDM. And more recently, prediction models, which takes into account multiple characteristics and the tests, which is a personalized risk prediction for the woman. So these are the ones on the right. The list are the predictors of GDM that all of us are aware of. The age, body mass index, both before pregnancy, during pregnancy, underlying medical conditions like chronic hypertension, a family history, previous poor obstetric history. But what happens is it's very difficult for us to counsel a mother when say, okay, you have blood pressure, you have you are a multiparous woman, and therefore your risk is this. We can only go by the individual characteristics, and hence Carl Moons and his team look to validate the existing prognostic models, which takes into account the multiple characteristics and gives out a single predicted probability. In the meantime, we also looked at a single test like HbA1c to see, can a HbA1c be used as an accurate test to predict? But what we found was we need to achieve a balance between the sensitivity and the specificity. As the HbA1c values were high, the specificity improved, which means you're going to have less false positives, but you're also going to miss a lot of the GDM patients. That's the bottom panel that you can see. So you really need high HbA1c to have a less false positive. Whereas if you don't want to miss out on any GDM, if you want to achieve a high sensitivity, then you're going to have a lower threshold of HbA1c, neither of which is optimum. If you're going to reduce a threshold, you're going to have a lot of patients who are unnecessarily labeled as GDM, and that defeats the purpose of using HbA1c as a screening test. If you increase the cutoff, then yes, you're not going to mislabel people with GDM, but you're going to miss out on those who have the condition. So at the moment, we are still not there to have HbA1c as a predictive test. During the pandemic, early on, when I was involved in writing the RCOG guidance on maternal medicine, we did actually recommend HbA1c test in the first trimester. And that is more to do with the fact that we could not do a glucose tolerance test. And therefore, if you're in situations where you can't, then HbA1c still can be a potential test, a single test to predict GDM. So if you look at some of the prognostic models, this is a model by Helena T and a team with whom I work with closely. So this model has been validated to predict GDM. And if you go into the website evidencio.com, it's freely accessible. You can just Google Evidencio and gestational diabetes, and it will give you this model. And you can then put in the details of the mom you are looking after. And it will, I can see at the bottom, it says, for this particular woman, the probability of developing gestational diabetes is 76%. So what it allows you to do is it allows you to communicate with the mother, and they're also more likely to engage with healthcare professionals in interventions that could reduce their risk, and also help us to communicate with other healthcare professionals that this is a high-risk mother, taking into account. These are simple things that we take into account in everyday clinical practice, but it will give you a specific probability of risk. And the model did perform. It has got a really good calibration. What it predicts is what you observe. So these are the two measures to look at the performance of prediction models. On the left is what we call a calibration slope. A slope of 1 is very good. So which means if you predict somebody's risk of having a GDM and they develop GDM, if you predict somebody doesn't have it, then they don't have it. So what you predict is actually what you observe. So prediction models, calibration is in fact considered to be more important than discrimination. And discrimination is what proportion of those women are correctly identified to have GDM. In Helena's model, 77% of them have been correctly identified, which is far greater than the other single clinical characteristics or even HbA1c that we looked at before. And the graph at the that you can see at the top is what we call a net benefit or a decision curve analysis. What it shows is compared to a policy of treating everyone as if they have GDM, or a policy of not considering anyone to have GDM, using a selective method like the prognostic model is clinically beneficial. So you can see that's the net benefit. This curve is meant to be between the dotted red line and the blue line, and which is what it is. And you can see most of the models, of which one of it is T et al., have got a net benefit in terms of their use in predicting GDM. So the next what we wanted to do was, can we predict which of the mothers with GDM are going to have complications? You know, we have a variety of GDM. Some of them are quite well controlled on diet alone. Some of them would need metformin. And here in UK, we are very comfortable with using metformin as a drug of choice, first drug of choice for gestational diabetes. I know that many countries, or some of them don't, or some of them would need insulin. But we do not need to consider all of them to have the same sort of risks, because a GDM who's well controlled on diet with a normal sized baby could be a different story with somebody who's on insulin. But what we want to do is very early on, once you diagnose somebody has got gestational diabetes, how can we stratify them by risks? How can we identify those women who need frequent monitoring in pregnancy and those who can be reassured and just be kept an eye on the glycemic indices? And then with Helena's team, we developed the personal GDM model, and we can see that these are the predictors that will provide an individualized risk of having a severe complication for the baby or a hypertensive disorder in the mother. This is just in the process of being published. So it should be coming out either this year or early next year. And as you can see, the model performs very well calibration-wise. So this will help to prioritize those women who need closer monitoring and those who probably don't need that much of an intense monitoring. And also those who can be safely taken to 40 weeks and more, and those who need to be delivered much earlier. So what do these things mean for implementation? So at the point of diagnosis, it helps us to identify who needs close monitoring. We can start targeted interventions, which I'm going to talk about later. And if you are in a setup like the National Health Service, where we are based, it also helps us to optimize the resources. And it helps in any healthcare setting to minimize the resource waste. Okay, what can we do to prevent gestational diabetes? Is it possible to prevent gestational diabetes? So we established a large consortium. I'll talk more about that shortly, where we looked at the individual participant data of women who have been recruited to the studies and showed that a diet and physical activity-based intervention, as you can see here, reduces the risk of gestational diabetes by 25%. We can reduce the risk. And this is a large reduction. A 25% reduction is quite large. And there is not one single diet and physical activity. It's broadly the ethos of having a healthy diet, avoiding the unhealthy food, increasing the physical activity in pregnancy does make a difference. We also did a trial in East London where about 80% of our women are from ethnic minority origin, a large number are from South Asian. And in the ESTEEM trial, 3/4 of our mothers in the trial were South Asians or of Black origin. And we wanted to look at the effect of Mediterranean diet in pregnancy. Now, you could ask, how are you going to make women in East London of ethnic minority origin to have a Mediterranean diet? So we broadly took into account the key components. So we gave them olive oil, and we also advised them to take nuts in pregnancy. In fact, we gave them nuts in pregnancy, a handful of nuts every day. And we also asked them to do the swap. So if they're using ghee, and then we said, okay, why don't you use extra virgin olive oil instead? Reduce the amount of red meat, take a lot of fish, avoid sugary drinks. So it was a simple food substitution. And what we found at the top, you can see the ESTEEM in the forest plot, is there was a 33% reduction in gestational diabetes. And this is mainly a diet-based intervention. It's a very pragmatic one. There was no intense course. Women came and along with the routine hospital appointments. And another trial was running simultaneously in Spain at the same time in St. Carlos team. And this was predominantly a Caucasian population. What's interesting is they also used a similar intervention and found exactly a similar reduction in gestational diabetes. And we combined the two studies together. You can see this is a massive reduction, a 33% reduction in gestational diabetes. So it is possible to prevent our mothers from developing gestational diabetes in pregnancy. So our suggestion is incorporate diet and physical activity within antenatal care as part and parcel of the advice we give mothers, along with folic acid and iron. Also to talk about diet and physical activity, we strongly recommend a Mediterranean diet be incorporated within the guidelines. Even if people can't afford or do not have access to all of the components, they can do food substitutions. They can focus on a predominantly a seafood diet rather than a red meat diet, avoid sugary drinks. And the current work that we're doing is we're trying to identify subgroups. We want to know, are there specific groups of women who benefit more from this intervention, or is this intervention applicable to across groups irrespective of their age, ethnicity, parity, pre-existing medical condition? So this is an ongoing work that we currently are doing that is funded by our NIHR or funder. So when I first started, I talked about the longer term outcomes beyond when the mother leaves us, what happens to her. We know that 4 in 10 mothers who develop gestational diabetes do develop type 2 diabetes, particularly in the first 2 years of pregnancy. And no health system so far, despite having guidance that we do need to keep an eye on these women by doing HbA1c every year if they have GDM in pregnancy, the follow-up is extremely poor. So what we want to do is, what can we do to predict which of these women with GDM are going to develop type 2 diabetes? what we found was, as you can see at the very top, the higher the BMI, the risk of developing type 2 diabetes increases. The ethnicity is a very strong predictor. And also what's interesting is the actual glucose tolerance test values. If they had a very high glycemic values within the glucose tolerance test, they were more likely to develop type 2 diabetes. And the earlier the gestational diabetes is diagnosed, the more likely they are prone for developing type 2 diabetes. And what we currently are doing is we currently are doing 2 pilot studies on methods to prevent progression to type 2 diabetes. Until now, nobody has looked at the immediate postnatal population. People have looked at interventions long time after delivery, but what can we do in the first year after delivery that can prevent their risk of developing type 2 diabetes? So we're running 2 pilot studies. One is the Omaha, where we are continuing metformin after delivery, or starting metformin if they were not on metformin in pregnancy to prevent GDM. The second one is considering the significant benefit that we observed with the Mediterranean diet. We want to see whether such a diet in the postnatal period could prevent type 2 diabetes following GDM. So moving on to weight gain in pregnancy, we know there are Institute of Medicine guidance in the US, which is what we currently have globally, which has recommended a certain amount of weight gain for women according to the different BMI when they enter pregnancy. And what we also found was this seems to be the optimal weight gain. Gestational weight gain above or below the guidance seem to be associated with adverse maternal outcomes. So we have a broad idea of the recommended weight gain in pregnancy. What can we do about in improving the outcomes? So we first did a systematic review about 10 years ago, when you did a meta-analysis of the existing studies, and we found there were about 44 trials at the time showing there is a beneficial effect with diet and physical activity interventions. And there was a lot of interest in the media about the benefits. But what we didn't know is whether such interventions also had benefit on actual clinical outcomes as well. And then what we did was we established the International Weight Management in Pregnancy, the IPD Network, which brought together all of the countries who have done trials in this area. They shared the data with us, so it gives us greater power to answer the question. So when we did the analysis last time, about 3 years ago, there were 12,000 pregnancies. It is a live database, and we currently have 60,000 women who have participated in randomized trials, about 50,000 of them with GDM as an outcome. So as you can see, there is great interest to look to see what we can do to improve pregnancy outcomes. Now, what I would particularly like to highlight to this audience is you can see the red dots on where the trials have done and who've shared the data. What is so striking is this big gap that you can see in the South Asian region, as well as in Africa, as in Latin America, the regions where obesity and metabolic diseases are the highest burden, but where we also have a paucity of data that's coming out of this region. We have observational studies, but we do not have randomized studies. So what we are able to do, and which is, I find it difficult today talking to you, sitting in UK, and I am still only extrapolating data that's coming from the global studies. I am not talking about data that's come from South Asian countries. I'm not giving you data that's come from Africa or Latin America. I think we only have one study from Sakati's team in Brazil. We really need more such studies. Yes, we can do some extrapolation with terms of ethnicity, the South Asians who migrated from the parent countries to the other countries. But we really need to know what's happening on the ground. So if you are interested in research, I would really say, please, can we spend more time looking at this important question? And I think the funders also will need to prioritize this question. So what did we find? So we found that, yes, there is a significant difference in reduction in weight gain in pregnancy, be it mainly diet-only interventions or physical activity-only interventions or a combination of diet and physical activity. It works. Whatever you do, trying to have a systematic approach does make a difference in reducing gestational weight gain in pregnancy. It does also have a beneficial effect in reducing cesarean section. There's a 10% reduction in cesarean section. And we already looked at the massive reduction in gestational diabetes with the diet and physical activity-based interventions. And what we also found was these benefits seem to be consistent across subgroups. So irrespective of the body mass index of the mother, irrespective of the parity or ethnicity or socioeconomic status or pre-existing medical condition, the beneficial effect of diet and physical activity seems to be consistent across the subgroups. And the second thing which we also found was, and a reassuring finding is, they had no adverse effect on the baby. Very often, moms are quite concerned, oh, you're asking me not to eat for 2, but is that not going to make my baby small? So we can reassure moms that a healthy diet and physical activity, you can do the simple physical activity. You can do cycling, you can walk, you can jog. It's absolutely safe. There is no risk of preterm birth, no risk of preterm rupture of membranes, no risk of antepartum hemorrhage. It's absolutely safe to the offspring. And our findings led to the UK guidance. So the chief medical officers from all 4 nations have used our findings to recommend physical activities in pregnancy. And the aim is to have 150 minutes of physical activity every week. And there is a variety of activities: swimming, dancing, walking, climbing. It's absolutely safe to do in pregnancy. So that brings me to the end